Sure.
Yes. So, good afternoon, everyone in India, and good morning to everyone across the world in UK. This is the OrthoTV UK in association with Northwest Education Academy program. And to introduce today's speakers and the topic, I hand over to our moderator and course chairman, Mr. Ravi.
Thanks, Neeraj. Good morning, everybody from UK, and hello to all worldwide viewers watching this live webinar organized by NWEA and OrthoTV UK. Thanks for joining us on a Sunday. I think we've had a great success on this platform with previous webinars. We've had almost 2,500 viewers joining us live and seeing the recorded version. So it gives us kind of an encouragement to bring distinguished speakers to talk on some topics which are relevant to all orthopedic surgeons, especially with today talks, all upper limb surgeons across the globe. In today's webinar, you can see as per the program, we've got the distinguished speakers talking on managing challenging rotator cuff tears. And as you all understand that rotator cuff disease is one of the commonest shoulder pain coming across to patients as well as to orthopedic surgeons. And our speakers will give their views, how do they manage them and how do they get these patients better and allow them to improve the quality of life. We all understand how important it is on these patients to have a good sleep pattern. And we've seen with the recent literature that rotator cuff disease and the pain can have a especially impact on the sleep disturbance and subsequently quality of life. So without a further ado, I'll introduce our first speaker, Ellie Richardson. Ellie is one of the senior shoulder specialists working with leading upper limb surgeons in Manchester region. She has an MSc in with distinction in advanced MSK physiotherapy practice, and she is active member of various regional as well as national shoulder and elbow surgeons group and the physiotherapy group as well. Apart from her extensive clinical work, she has interest in academic work. She's delivered various lectures on different platforms. She has been actively involved in publishing her research work as well as written chapters in the shoulder-related books with Prof. Fung. She's got a strong sporting background and she's associated with Manchester University Sports Unit as well as national governing bodies. She's going to give us a view on shared decision-making in atraumatic rotator cuff tear, and she will also talk about evidence-informed rehabilitation for cuff tears. Over to you, Ellie.
Thanks, Ravi. That was lovely. I'm just going to share my screen to make sure that everything's coming up. Okay, can you see that? Yeah, okay, so I'm going to dive straight in because I've only got 10 minutes to do my first talk and then 10 minutes to do my last one on evidence-informed rehab. So I'm going to talk about shared decision-making in the atraumatic rotator cuff tear population. And if I start straight away with what is, I think, a common opening gambit that we see as physiotherapists during that initial consultation if someone's been referred in from a surgeon. And it looks something like this. So my consultant told me that I have a rotator cuff tear and to try physiotherapy, but if that doesn't work, he can fix it. So I'd just like you to hold that quote in your head as we go through this presentation, and I'll revisit it along the way. So what do we know about atraumatic cuff tears? Well, we know that 20% of the population have full thickness tears, 2/3 of these aren't symptomatic. And we rotator cuff tears are more common as we get older, but interestingly, the risk of those tears becoming associated with pain doesn't increase as we age. So those factors together have led to the term in imaging, normal age-related changes within this patient cohort group. And it does highlight the real challenge of correlating somebody's imaging report with in the absence of trauma with the actual pain presentation they might have in front of you. So when it comes to the management of, in this group, rehab versus surgery, so we know that they offer fairly comparable outcomes. So given that, it's obviously important to know what are the risk factors associated with poor outcome and how can we stratify patients into different groups. And we know that the biggest risk factor for poor outcomes is actually expectations of how well people think they're going to do. So if you think you're going to do well with physio, you more likely are. So if we go back to that original quote, my consultant told me that I have a rotator cuff tear and to try physiotherapy, but if that doesn't work, he can fix it. If we look at the language used there, which again is something we commonly see, it's very emotive. On the one hand, it's essentially I've been presented with a problem, a tear. I've been given an option to try in the short term, but ultimately, if that doesn't work, the root of the cause can get fixed. Obviously, the word fixed is kind of quite emotive. So what does that sort of mean for us in terms of buyers, physios, and what's our role in this situation when someone is sat in front of us using this sort of language? Well, in terms of obviously our role as therapists across the board for any condition, we want to increase the expectations and lower concerns in relation to rehab. And facilitate the shared decision-making process, because without patient engagement, we're not going to do well in any patient group. But in terms of shared decision-making, it's a common term that's used in sort of healthcare at the moment, bit of a buzzword, but what do we actually mean by that and how can we sort of take steps towards doing that? So shared decision-making is it's basically an approach to facilitate the patient journey towards treatment choices in line with their values and informed by scientific evidence. In terms of the atraumatic rotator cuff tear group and generally in MSK research in general, there's not a lot in terms of patient decision aids, but DeVille et al. In 2019 did do a lovely study that did actually design a patient decision aid underpinned by scientific evidence to basically depict the management options of people with rotator cuff pain associated with a non-traumatic cuff tear. And they used a patient decision aid that basically, hopefully when we use patient decision aids, we know that that generally results in management options that are more in line with patients' beliefs and therefore more likely to get them engaged in the process. I really like this article because it basically combines qualitative and quantitative research. So it's got the quantitative aspects in terms of what we know, surgery versus physio, or not versus, surgery compared to physio in this patient group, as well as combining the qualitative aspects of basically common concerns or things that patients voice in this group when they're working out which option might be best for them. So what I'm going to do is basically go through the decision aid that's there. So it's presented, it's actually on a double side of A4, so it's a dead easy thing to use. A caveat here is it's not been looked at en masse or researched en masse in this patient group. You know, this is kind of a fairly novel decision aid, but I just think it's a really nice teaching tool and could be something that you could use almost immediately in clinical practice. So the heading for this decision aid is, I have a tear in my rotator cuff tendon, what treatments should I choose? And essentially there are three options. So you could have physio on its own, you could have surgery to repair your cuff and then physio, or surgery without a repair and physio. And there's a really nice sort of visual representation of who generally does well out of 100 patients or who feels dissatisfied. And you can see across those three options, essentially it's very comparable with no significant difference. Physio performs slightly less well. So 11 out of 100 patients not satisfied, 5 out of patients not satisfied with the repair and physio, and then 6 not satisfied otherwise. But I think it's really good because you generally get patients sat in front of you saying things like, you know, how will physio help? Will it help? Would I have been better off going for surgery? Are my outcomes better with surgery? And I think what's nice with research like this is it gives us as therapists confidence that certainly within a 2-year time frame anyway, we can provide some sort of reassurance, objective reassurance that actually you're in a place where you're likely to do well. After this sort of visual representation, DeVille then go on to sort of display virtual statements in the form of a decisional balance. So then it jumps to the qualitative aspect, which basically looks at quotes that patients have made and whether they are true, false, or whether they're unknown in terms of our sort of evidence base at the moment. So generally, if you have a decisional balance and a patient can go away and look at that after being bombarded with information, generally we know it helps reduce that concept of post-decisional regret, which in this situation might manifest itself as someone walks out of the consultation, doesn't understand what's happened and thinks, oh, actually, I didn't ask that, or I'm not really sure this is right for me. And that's where these sorts of things can be really helpful. So if I jump straight into the first one, I prefer to have physio rehabilitation only on its own because it's not my dominant arm. Shoulder pain's normal when you get older, and my opposite shoulder can have a tear, be pain-free and function normally. So you can see here, true, false and unknown. They're things that are written to sort of qualify each statement. We don't know whether arm dominance matters. Shoulder pain isn't normal as we get older, although most people will have an episode or two of shoulder pain in their lifetime. And we know that you can have a tear in your shoulder and it be perfectly pain-free and function normally. Oh, I've gone backwards there, sorry. I prefer not to have physio because physio won't repair my tear, that's true. The tear will increase in size, that's true for some people. As my tear increases in size, I'll have more pain. We know that that's not necessarily true. My pain will worsen over time and my arm will become useless. Again, we know those things aren't necessarily the case. I prefer to have surgery because my pain will reduce quicker. In the short term, we don't know. Long term, up to 2 years, we know that's not necessarily the case. I can't wait 2 years for the problem to go. Well, you shouldn't have to after sort of successful rehab after surgery. Tears need repairing. Again, that's not necessarily the case in this atraumatic group. Without a repair, it's not possible to have a normal functioning shoulder. We see people doing fantastically. We've got multiple irreparable cuff tears. So again, we know that's not the case. I got very good results with my other shoulder in the past. Therefore, it will be successful for the second. We don't know that, but I think that's really interesting because if we know that patient expectations are key, I think although it's unknown, it's certainly a very important thing to consider and listening to the patient and how they are voicing that or framing that when coming to our decision as to whether rehab's appropriate or to go down a different route. And it will stop the tear increasing in size. Certainly surgery should do that. I prefer not to have surgery because I'm not, this is actually a French article translated into English. So that sentence at the top, this is just screenshotted from it. It doesn't actually make grammatical sense in English. But what they mean is I'm not guaranteed to have a normal shoulder after surgery. True. It's possible to get better without surgery. Again, that's true. Surgery is a big thing. Risks exist. I won't be able to continue caring for my family members or friends who need help in the weeks following surgery, and I'll have to take time off work. So they're all things that are true and genuine concerns that are voiced by patients. So in this group, I know that shared decision-making is often, as I said, something that is kind of branded around, but perhaps, are we doing it? We know that it should be a central aspect to healthcare generally. It should facilitate patient understanding. It should elicit patients' individual preferences and hopefully transform those beliefs into kind of management options in line with them. But are we doing it, and could we do it better? So if I go back to that original quote, my consultant told me that I have a rotator cuff tear to try physiotherapy, but if that doesn't work, he can fix it. It would be lovely from a physio perspective, and we'd certainly be smiling ear from ear if we heard a different version of that more consistently and something that looked like this. My scan showed that I have some age-related changes in my shoulder, which may be contributing to my pain. My consultant told me that 3 treatment options exist, all of which are likely to help improve my pain. We discussed the pros and cons, and I feel that rehab would work best for me. Thank you.
Thanks, Ellie. Such a lovely talk and a very important message you've shared. I totally agree, and I'm sure rest of the panelists would agree that it's not an individual decision, it's a shared decision making, and it's a teamwork which allows us to get our patient back to what they want. And I think we do try and meet the expectation of the patient by this process, and it is so essential that we have this team who's working along with the patients to get them back and meet the requirements. Ellie, just a quick question. do you assess patients from the psychosomatic point of view when you start treating them?
In terms of formal measures, no, not in terms of a very formal sort of psychosocial measure. Some people might use certain patient-related outcomes in that group, but really the biggest thing is letting the patient talk to you during that initial consultation and letting them finish their story and their opening gambit and trying to sort of draw out their beliefs and preferences along the way. So I think it's more about listening to the patient, validating their experiences, and then working with them towards their rehab goals. So no, I don't routinely use a specific marker. If something really flagged up that was out with my scope, then I might sort of look into that or refer on for a different type of management alongside, but not routinely.
Sure. Well, I mean, you clearly said that we shouldn't be using the word like fixing it, because as an orthopedic surgeons, we only repair and we don't fix from surgical point of view. Are there any prognostic factor you've seen in managing these patients from your side that that, we always talk about pick up a winner? And are there any kind of silent features you see in patients which allows you to decide, okay, this patient will do better than other?
So I will talk about that in the evidence-informed rehab a little bit later on. So sort of positive and negative prognostic factors, certainly in the sort of like massive rotator cuff tear group. When it comes to atraumatic cuff tears, I think it's like any MSK presentation. So it's things like being, unfortunately, your socioeconomic status matters. If you're a middle-aged woman, you seem to do less well generally with shoulder pain. If you're overweight, you do less well. If you're less educated, you seem to do less well. These are things that are across the board. And I don't believe, correlation isn't causation. So it's not something that I would see someone walk in through my front door and be like, oh, you're not going to do well, or you are. I don't think that's fair. You shouldn't write someone off when you see them. I think it just might highlight how even more important it is to listen to that patient's story. But in terms of the objective markers and things that we know means people are likely to fly nicer through the rehab process, I'll talk about that in my talk later on.
Thanks, Ellie. So we'll move on to our next talk on a partial thickness cuff tear, which one, when and how, and evidence-informed approach by Andy Wright. So I'll introduce Andy. Andy is an upper limb surgeon at Wrightington Hospital, which we all know as a center of excellence. He is fellowship trained in the northwest part of the UK in Wrightington, as well as in Florida. His clinical work is mainly shoulder and elbow work, with more emphasis on arthroscopic clinical practice. Apart from his clinical work, he's got a keen interest in research, academics, education and training, and he's quite actively involved in the regional and the national courses and workshop held on elbow and shoulder arthroscopy work. So here to you, Andy, fire away.
Thank you very much, Ravi, and thanks to the Northwest Educational Academy for inviting me to speak. I've got to start off by saying I'm really fortunate to be part of a strong Wrightington family that you can see in some of these pictures here on my opening slide. We're a 14-strong upper limb team, and really we're all indebted to the giants who've gone before us. You can see Sir John Charnley in the window there, who clearly pioneered the hip replacement surgery at Wrightington. But in terms of upper limb, we're really indebted to Professor John Stanley, who's in the centre of this picture here, who founded the upper limb unit back in 1979. It's been a sad year for us, unfortunately, because we lost Professor Stanley earlier this year, but the foundations that he's laid continue on. So this is what I'm going to talk to you about today. Partial cuff tears encompass a huge array of pathologies, and you can see 3 on the screens now. Starting from left to right, we've got articular-sided tears. In the center, these tears that started on the bursal side. And then finally, interstitial tears, so tears away from the footprint. After an introduction, I'll try and define and categorize them. We'll give some time perspective to their management, and then appraise the evidence on different surgical interventions. So it's always nice to go back to the start with these, and this is a diagram from Codman back in 1934 that highlights the changes that occur at the muscular tendinous junction. You can see all the different pathologies that start these partial thickness tears, and the arrow on the undersurface is what he coined rim rent tears, which a lot of us probably still use today. The cause of a partial thickness tear can be degenerative, traumatic, or secondary to instability. And in fact, these are really common, much more common than full thickness tears, and can be more painful. So it's an important thing that we're going to see in our practice. However, as Ellie pointed out previously, a huge number of these tears will be present in asymptomatic shoulders. So it's really key that we're getting the diagnosis right. It's important we're not talking about apples and oranges. So are we all talking about the same thing? So let's define the pathology we're talking about in the first instance. The available classification systems for partial cuff tears are based on arthroscopic findings. I think the most common one we'd all use is that from Ellman, and here's a cut from his original article at the top of the screen there. And he defined the tears as I did on that opening slide in terms of articular, bursal, or interstitial, and then defined the thickness. And if you remember, the thickness of the cuff at the footprint is about 1 to 1.2 centimeters. Then we can see here that grades 1 and 2 are those that are less than 50% the thickness. It's a really nice schematic diagram which gives a visual representation of what we're talking about here. So so grades 1 are very, very subtle fraying and damage to the tendon, where it be on the articular or bursal side. Grade 2 is when it's getting larger, and grade 3, I think we can all quite commonly recognize when the cuff's hanging on by a thread there. Snyder went on to sort of further classify these, and he did a lot of work by assessing these arthroscopically and passing a PDS suture through the area of tendon interest, and then assessing this both from the shoulder joint and from the bursa to not only look at the degree of tendon damage, but also the AP width that damage was present in. And he gave a sort of more extensive classification from 0 through to 4, where 0 is normal tendon, and grade 4, there's flap formation tendon retraction greater than 3 centimeters in an AP direction. I suppose most of us use the Ellman, and that Snyder one is perhaps more important in research terms. Unfortunately, the reproducibility of these classifications has been poor, with moderate inter-surgeon agreement when assessing these. So it can be difficult to translate practice between surgeons. I think we all probably use an MR scan to initially assess these cuffs, and it's the gold standard of assessment. But we've got to remember that we're using an arthroscopic classification system for an MR diagnosis, so there are challenges there, and that's been shown in the evidence with good agreement intra-observer, but between different observers, there's poor agreement about the grade of cuff tear seen on MR scan. So it can be really difficult to compare these. But we know the outcomes from conservative treatment are good. And studies have shown that the vast majority of these partial thickness tears of all patients in all grades will improve with a supervised physio program. And so it's really important that the language and terms we use, as Ellie pointed out previously. Teamwork is absolutely key then. Teamwork with you and your radiologist to assess these partial tears, and critically teamwork with you and your physiotherapist, using that appropriate language that Ellie talks about, and empowering the physio to get the best results for your patients. Okay, so whilst we refer all patients initially off for physio, and the majority we know will get better, clearly there will be some that come back with persistent pain and symptoms. So I'm going to go through a couple of papers now that look at those patients that are more likely to come back and see us for that will require operative intervention. And at the bottom here, I've got a QR code. So if you use your camera phone, you can go through to the PubMed citation of this paper. And that'll be throughout a few slides, so I'll probably forget to say that again, but if you see that QR code, you can use that to get through to the paper I'm discussing. So the first is this paper in 2019 from a Turkish group. They looked at over 270 patients. And it was this retrospective review of patients they saw over 2 years. The vast majority improved without surgical intervention, but they looked at the factors of those patients who came back to surgery. They found significantly they were more likely to have bursal-sided tears. They were going to be of younger age, and they were better functionally, so they had less comorbidities, fitter patients. A relatively similar study again they had over 270 patients, and here all patients they saw in this study went for 6 months initial conservative treatment. Those patients they assessed after 6 months who still had sleep disturbance and loss of activity, they were discussed having surgical intervention. And again, they found bursal-sided tears were much more common. This time, the depth of tear was important. So those with over 50% of the tendon torn, although I suppose we have to take that with a pinch of salt when we look at our how reliable we can diagnose the thickness of those tears on MR scans, as I spoke about earlier. And they found some that hand dominance had some impact as well on decision making. The final slide on which ones. This is a great study from the Moon surgical group over in the US. And they were looking at full thickness tears in this study, but I'm sure it can be applicable to partial thickness tears. They looked at the factors that might predict failure of non-operative management. And in this graph you see here, so this shows that the percentage of patients who are surgery-free, so clearly everyone starts off surgery-free, so 100% of patients surgical-free. And then they looked at times, this is days, so this is roughly about a year. You can see where before these graphs plot off. And the difference between each of these lines plotted on this graph is the expectation that physio would lead to improvement. So those at the top here had the highest level of expectation that physio would improve their movement. So it's really striking how much that makes a difference. So to sort of build on what Ellie spoke about earlier. All right, so we've looked at, we know that many get better with time, but how long shall we be considered pursuing conservative treatment, and over what time period might a tear progress in size and complexity? So partial thickness tears do progress with time. Work from Moll and Keener show that 40% of partial tears progress in size and annual review. But importantly, that's not progressing to full thickness tears, that's progressing in size of partial thickness. And they looked at those in combination of ultrasound and MR scan. I think most importantly is this study at the bottom here, in the bottom bullet point from Canada. And they showed, that's from this year, so a really recent study. And they showed that over a 28-month period, only 5% of these partial thickness tears would progress to a symptomatic full thickness tear. So it's really quite a long period. So I think that gives further weight to our conservative management strategy. Here's another study to build on this. The study's from Kim here, and what they did, so all patients presenting with a partial thickness tear, they put into two groups. Group one, which is the darker line on these graphs here, went for immediate surgical repair. Group two went on to have 6 months physio before then going ahead with surgical repair. And you can see here in the VAS pain scores, there was a significantly less pain in those patients who had the 6 months initial physio. And in the American shoulder and elbow score here, at 6 months again, they were scoring better. Those patients had that initial conservative management. So real strength in considering that early conservative management. All right, so we looked at which ones we need to watch, how long we can watch them for, and now we can have a look at what we should be doing with them surgically. So there's good evidence that those tears less than 50% of the width of the cuff, so those grade 1 and 2s here in that Elman classification, do well with debridement plus or minus subacromial decompression. So I think most of us would agree that those grade 1 tears are pretty easy to pick up arthroscopically. They're sort of minor fraying of the cuff. Equally, those grade 3 that are more than half the thickness of the cuff, when we see that cuff sort of hanging on, they're quite easy to see. Perhaps more difficult is those grade 2 tears in the center where it may be coming up to half the thickness of the cuff. So we've got to remember we can use our arthroscopic probe to come in there. The tip of these, the majority of them are 3 millimeters, or the vast majority now have some measurements along here. And we can get that in there and measure our thickness. And certainly if it's getting near that 6 millimeter difference, then we need to be perhaps thinking of doing more than just debriding and decompressing. So the big debate is, if we're going on to repair it, should we be doing an in situ repair of the cuff? Or should we be completing that to a full thickness tear and then repairing that down? Advocates of in situ repair would say that it's a more anatomic repair because we're not sacrificing those intact fibers. We're also not lateralizing the cuff with the debridement and reinsertion that may alter the cuff biomechanics. Those people who favor completing the tear to a full thickness would say those remaining fibers are going to be pathological as well. And are we preserving poor quality tissue that may tear at a later date? So let's have a look at the evidence behind that. So this review, E4 review, was a really good summary of the evidence. So it's quite a lot on the slide here, so we'll just run through this a bit in time. So the first 3 studies here are all looking at articular-sided tears, and they randomized patients either into debridement or, either into in situ repair or completion of the tear in full thickness. The final study here is the only one that's looked at bursal-sided tears, doing that same randomization. And so there's a lot of text on the screen, but let me distill that all down for you. And as we can see under that red, no significant differences in all of those types. So all those studies found outcomes were equal comparing to repairing in situ and completing the tear and repairing it. So I'm just going to finish on this H&E slide. I think it's important in all presentations to put some histology in there. I think this sort of gives a view into my own preference for treating these. So looking at each of these slides, so, this is a great study from the Korean group. So group A was the control tissue. So these are samples of cuff that they took whilst performing humeral nails for proximal humeral fractures. So no cuff pathology. The C there is a section of tendon taken from patients with torn tendon. So patients they operated on with partial thickness tears, and this is from the torn side of the tendon. And B is from the untorn tendon. So they took a sample of tissue there, and we can see there that clearly that untorn tendon is not structurally normal. It's nowhere near that structural strength of tendon in A. And really, I think that's really important. My concern with the in situ repairs is that we're preserving poor quality tendon, and we may be compromising our repair there for a later date. So just to finalize the key points we've picked up on there. So the majority of partial thickness tears will resolve with conservative management with our physiotherapy colleagues. There are known risk factors for progression for surgery, and we discussed those bursal-sided tears, those with a higher thickness of tendon tear, and those more functionally active patients. There's no harm in at least 6 months of conservative treatment, and in fact, patients often do better surgically for this. So you can consider this a prehab. Those lower, less than 50% tears do well with debridement and subacromial decompression. And the evidence has shown equivalent outcome for repair techniques for those higher grade partial thickness tears. Thank you very much.
Thanks, Andy. Such an extensive review of literature and kind of a very succinct talk on a very important talk here. I think there is a myth, isn't it, that full thickness tear should be more symptomatic compared to partial thickness tear, because that's the name people would have in their mind once they've been told on the scan. And I do see that in my practice as well. The partial thickness tear patients are more symptomatic compared to the full thickness, and it's it's a dilemma of managing them. So Andy, in terms of your preference in managing these patients, if consider you have a 35-year-old athlete coming to you with grade 2 partial thickness, a bursal side tear, how do you go about managing that patient?
Yeah, so I mean, clearly the full history is really important. So you want to, in terms of athletes, you want to know what their sport is. Are they an overhead athlete?
Javelin thrower or something like that.
Yeah. So I think that's really important. What stage of their career are they at? So 35, they may be getting towards the end of their career, I suppose, unless they're a golfer perhaps, and they may be coming into their prime, as Justin Rose is showing us at the Masters. And obviously there's the stage of their season is all important factors for that. But I think the evidence is clear that those sort of smaller partial thickness tears will do well with conservative management. So I would clearly, I think we all have really good relationships with our radiology colleagues. You want to be sure that cuff's not hanging on by a thread, that it truly is just a partial thickness tear of that cuff. And then let our physio colleagues, do their work with, maintaining close relationship and teamwork, as I spoke about previously.
Yeah, I think you're right. We just got to have a patient-specific treatment, isn't it? Now, the other question is, do you see this? With the literature, there is such a varied number that this sort of tear will progress to full thickness tear, whether it's asymptomatic or symptomatic to begin with. And what do you see in your practice? Do you see the symptomatic partial thickness progress significantly over 24 months, or does it take a while for them to progress to full thickness tear?
So progression to full thickness tear, I suppose, isn't generally my greatest concern. I think if someone's having 2 years of persistent pain and symptoms despite active engagement with physiotherapy, I would probably have made a decision within that period. And I don't know if Ellie wants to come in here in terms of a physio strategy. I'm sure. So the physios at Wrightington, we have clearly close relationships with, and they would probably contact me before that period and say, look, this patient's just not improving, and so I wouldn't be waiting that sort of period of time. So I think the literature, as I said, is reassuring that progression to full thickness is not going to happen within 3 or 4 months. It's going to be over a prolonged period, and therefore we can let that conservative management strategy play out its course.
Sure. Ellie, you're mute.
Just to add to that, I completely agree with what Andrew's saying. From a rotator cuff related type pain issue, whether that's a partial tear or not, we generally would have a threshold for time for knowing if someone's going to do well. And I will talk about that in my evidence-informed presentation. But generally, people who are going to do well will have seen quite significant changes by the 12-week mark, usually before. And that needs to be quite functionally meaningful changes to them. If they haven't seen those improvements by then, and we haven't seen improvements in objective markers along the way, whether that's range, handheld dynamometry or whatever, then that's when we will be having that conversation again before the follow-up with the surgeon, so that everybody was on the same page.
Excellent. Thanks, Andy. Thanks, Ellie.
Thank you.
So we'll move on to our next speaker, Mr. Puneet Monga. Puneet is giving a talk on irreparable cuff tears and what are the options available and the outcomes. So let me introduce Puneet. Puneet is a good friend of mine. He is an established upper limb surgeon working at Wrightington Hospital. And you've seen the stalwart from Andy's slide from the upper limb unit. And Puneet carries the heavy responsibility of carrying that legacy forward. He's got an extensive clinical practice, which ranges treating the common people, weekend warriors, to elite athletes. And he also deals with a lot of complex revision work referred to him from the referring units in the region. Along with his extensive clinical work, he's got a keen interest in research and academic. He's published, in various journals, written books. He delivers lectures on a national and international platform, and he conducts workshop on arthroscopic shoulder work as well as the reconstructive work for the shoulder. So here to you, Puneet. Mute, Puneet.
Oh, yeah, we have to have that mute moment in every Zoom webinar, isn't it? Yes, so thanks a lot for inviting me, Ravi. Can you see the screen?
Yeah.
Okay, excellent. It's a great platform. You guys are doing a great work. Thanks. I can't start the talk without giving credit to my predecessors. Sir John Chanley. He's the giant on whose shoulders we stand. You can see his operating theater from the 1960s, and the work he did changed the world of orthopedics and hip replacement and elective orthopedics. Moving on from him, you can see the operating theater I use now. Wrightington's kept pace with changing times, and then you can see on the picture on the bottom right, which is now expanded. You can see John Stanley, like Andy said, we lost him recently. He was a big loss for us. He was one of the founding fathers of our upper limb unit, along with Ian Trail. And it's a big legacy and giant shoulders we can stand on. Moving on to the topic which I've been given, which is irreparable tears. A common cause for confusion in nomenclature is between massive tears and irreparable tears. There is a clear distinction. Massive tears, like Andy described, you can classify them, and massive tears could be diagnosed preoperatively on scans, whereas irreparable tear, by definition, one has to attempt to repair it before we can declare a tear irreparable. The reason why this distinction is important is sometimes we can have a massive tear, say an acute recent massive tear, which is repairable. So not all massive tears are irreparable. And that creates a little bit of a dilemma when it comes to decision making. Although having said that, for most massive chronic retracted tears, they end up being irreparable. But there is a subgroup within that we need to think about where it may well be repairable. So that's something to clarify in our own minds before we proceed. The challenge with these difficult cuffs is the quality of the tissue. And we have different ways of describing it to our patients. The metaphor I commonly use is when you take a stitch through cheese or through cotton wool, that stitch just wouldn't hold. And you could do the best repair in poor quality tendon, it'll just cut through. So there's no point repairing very poor quality tissue because it just doesn't hold. And we have extremely high failure rates. In an irreparable tear, by definition, we're not able to bring the edge of the tear to the footprint and cover it completely. So the challenge remains the quality of tissue. And I can't emphasize enough how important it is for us to make the correct diagnosis. I still see patients occasionally who've been treated for cuff pathologies where they may have something unrelated. They could have, for example, a cervical nerve root compression, and which looks like shoulder pain on gross assessment. And I also see a lot of patients who come with scan reports in their hands saying, oh, I've got a cuff tear, can you fix it for us? And they've got a massive tear. And then they have another scan of the other shoulder and they're doing perfectly well. So a diagnosis is based on a good history, clinical examination, special tests and investigation, not just on investigations. So we have to go back to the basic and all these irreparable tears to make sure that the pain is actually coming from the irreparable tear, which you can see on the scan. So just a strong radiological finding doesn't necessarily translate into treatment. Although it is quite basic, but it remains quite important. Okay, I can't complete a talk on cuff without talking about subscap. It is my favorite tendon by far. It is massively understated, the importance of subscap sometimes. I think we surgeons and we physiotherapists, we are realizing how important subscap is. If we just look at this scapular osteology, you see the size of the subscapularis fossa is about the same size of the supraspinatus, infraspinatus, anterior spinatus combined. So the muscle bulk, which is provided by the subscapularis, and hence the strength provided by subscapularis, is equal to the rest of the cuff. It is very much possible to rehabilitate a person with a large irreparable supraspinatus and infraspinatus tear with an intact subscap by strengthening the subscap. And then, like Ellie said, you know, by actually focusing on the strengths, you can get a really good function. So, and I won't go too much into subscap because I'll spend the next 1 hour just talking about the subscap, if you know me. The issue with the kinetics, or where the direction of forces are in the shoulder, is, again, it's good to understand if you're dealing with shoulders. What the deltoid does, it provides an upward and a medial force, and it's best countered by subscapularis and infraspinatus, which provides a medial and a downward force. So if you don't have subscap or infraspinatus, when the deltoid acts, it just translates the humeral head proximally. So you get upward migration or proximal migration. And that is nicely countered by the rotator cuff, especially the strong subscap and infraspinatus. So one can have a tear of the supraspinatus at the top, but still the subscap and infraspinatus can hold the humeral head in the center of the glenoid and then allow the deltoid to work. And that's the principle. And I think that's the principle of rehab. When you have a massive cuff tear, if infra is missing, you can strengthen the subscap. If you got a large subscap tear, you can rehab using infraspinatus, because they're the ones who are providing the downward vector to neutralize the upward vector of deltoid. So I think for surgeons, understanding the basic kinetics of the muscles in the shoulder is quite useful to explain to patients. Okay, so that's some really basic facts, and we'll come to the main body of this talk, which is what are the options of treatment in an irreparable rotator cuff. And you know what, this list could be a lot longer. I could run into 2 or 3 pages. There's so many treatment options for irreparable tears. Some of them are published, some of them are not published. So I've restricted this to the options which have got some decent evidence base. None of the evidence is very strong, so I'll have to go a lot on my experience of having used different techniques. And when you see such a long list, you know for sure that none of them actually works 100%. So that's understanding, you know, the options available. But one thing we all agree on is option number 1, which is physiotherapy. So we'll go through them one by one. So what's the role of physiotherapy in irreparable cuff tear? I think almost every patient needs to have a trial of physiotherapy and rehab before they have surgery. And that's so important, because when none of the other options are clear-cut, we gotta choose the option which has got good evidence. Physiotherapy has good evidence. It is safe, and if the patient does engage in physiotherapy, the effects and the outcomes last forever. So physiotherapy wins over most others if it works. But the key thing for a surgeon when you see a patient is, when would physiotherapy work? And again, you know, you go back to what Ellie said and what Andy said. And this is a paper which I really like. I don't have those fancy QR codes like Andy does, but you can look at this. This is work from Jeremy Lewis and his team. If a patient believes that physiotherapy will work, it usually works. It's really simple as that. So then, if we know it works, then it is upon us as surgeons in our first consultation to emphasize and big up our physiotherapy colleagues that it will work. And there are some people who will listen to you and go with a positive mind, and there is a small minority who just cannot be convinced. So I would say, if your surgeon's treating with irreparable cuff tears, it is important that we emphasize that it will work for our patients, because it is quite very much the right thing to do. So patients who don't believe in it generally don't respond. So that's that bit for physio. And again, I'm sure Ellie will come back and talk a lot more about how she deals with that at the other end. The next option is suprascapular nerve ablation. In my practice, this has a role. We know that suprascapular nerve carries about 70 to 80% of pain sensation from the shoulder joint. I would usually request our radiology colleagues. We're surrounded by some fantastic MSK radiologists in Wrightington and in Manchester. So I'll request them to perform a radiology guided injection into the suprascapular nerve. Some of our anesthetists are happy to perform a phenol nerve ablation as well. But usually that is reserved for patients who are either too unwell for surgery or do not wish to have surgery. In my opinion, the nerve block works for a short period of time. And if they get a good pain relief, you can then get some good rehab in that window of opportunity that we have. Partial repair. Okay, so this goes back to Steve Burkhart's work and how he popularized this technique in the 1990s. And I use that quite extensively in my practice for many years. And you can see how during arthroscopy, you can see the subscapularis there on the right side and infraspinatus there on the left side. This is a completed partial repair. We've been able to perform part of the repair, and you can see the superior aspect of the humeral head remains uncovered. So does the supraspinatus element of the footprint, that remains uncovered. And this goes back to our understanding of the kinetics, that if we can restore the force factors of the subscapularis and the infraspinatus, we are able to produce a downward translation force onto the humeral head, which then allows the deltoid to work. It is again very reliant on a good rehab team working with you. If we just do this and leave the patient in a sling for 6 to 8 weeks and do nothing after that, it is guaranteed to fail. So if you're going ahead with this technique, it's really important you're working closely with your physiotherapist. And this is, we looked at our patients. Ravi, you might recollect, this is your work when you were at Wrightington, and we looked at around 20 patients. It was a retrospective review, and you can see from this particular table that almost all these patients had stage 3 and stage 4 fatty infiltration. So normally you'd say, oh, that's too advanced for repair. But we did a partial repair in these patients, and it's quite fascinating, the results. Almost all of the ones we could follow up had a good pain relief. All of them had a pseudoparalysis. These are patients with irreparable cuff tears with pseudoparalysis. And look at that, with partial repair and rehab, we are able to achieve 82.3% patients where the pseudoparalysis had improved. That was fascinating. So I think it has a role, and I think still in some patients where they fall in between superior capsular reconstruction and reverse, it does have a role. Certainly, if someone doesn't have the experience or the setup for performing a good reconstructive surgery, there is one option which is available, which is a partial repair. The issue with partial repairs is that over a period of time, the results start to drop off, and you start to see an increasing number of patients coming back for further surgery. And that's why we continue to explore other techniques. So the interposition graft here, again, our colleagues in Leicester have extensive experience with this, where they've taken graft jacket and use that almost to bridge the gap between the cuff and the footprint, and they report better scores post-operatively compared to partial repair. So that is definitely one of the options. Again, Roger Hackney from Leeds, he's been a strong proponent of the cuff patch, which is a synthetic patch, works very similar to the graft jacket, whereas graft jacket is acellular dermal matrix. This is a synthetic material. The advantage of a synthetic material of polyester type is that you get the same consistency every single time, and it's very easy to store these. I personally don't have experience with this, and I'd like to talk a little bit more about the option where I have got more experience for the last 3, 4, maybe even 5 years now. And this is superior capsular reconstruction, originally described by Dr. Mihata from Japan. Essentially what we're doing is bridging the gap between the superior glenoid and the proximal humeral using a graft. Now, there are different grafts which have been used by different surgeons. The original description was using fascia lata, but equally there have been different graft materials which have been used. It's a really nice review where different evidences for this procedure have been evaluated. And the key take-home messages from that review, this was published last year, is when you look at cadaver studies performed for superior capsular reconstruction, it reduces the superior translation, and it recommends that you need a minimum graft thickness of 8 millimeters when performing such a superior capsular reconstruction. When you use autograft with fascia lata, it shows an improvement in clinical scores, and the retear rates of the graft were between 5 to 29%. Whereas if one uses a dermal allograft, which is perhaps the most popular graft used for superior capsular reconstruction, we again see an improvement in clinical scores, improvement in the acromiohumeral distance, but the retear rates are higher. Studies describe anything between 15 to 45% retear rates. I think that's where the work needs to happen to improve that retear rate. It's worth discussing our experience. We have a big series. We have a large experience with superior capsular reconstruction, and this is the kind of patient you see. So this lady is 8 weeks, please, all the way up to the ceiling. So irreparable cuff tear,
on the side as if you're going to clap above your head.
And you can see
brilliant. And come down. Take your left arm behind your back.
So this is the kind of result we're seeing 8 weeks from surgery. And the main thing I find about superior capsular reconstruction, the results are more consistent compared to other techniques. And when we looked at our data, again, we looked at 3 years worth of our experience. We've been using the ArthroFlex graft. We had about 49 patients in the series, and our mean follow-up time was 19 months. We had a mixture of patients. We do get a large number of patients who have had surgery before. In fact, the majority of our patients, 33 out of 49, were revision patients. And we looked at the outcomes from superior capsular reconstruction, and we found that a majority of them, 82%, were satisfied. We had some failures. Most of them were on the glenoid side, but we also had some graft ruptures intrasubstance. The complication rate essentially is failure to relieve symptoms and re-rupture, and we went on to perform reverse arthroplasties on a majority of our patients for whom it didn't work. What is quite interesting is that we did not have any serious complications such as infection or CRPS. And the good thing about superior capsular reconstruction is it doesn't violate the patient's anatomy. And then we drill down into which patients the superior capsular reconstruction works and where it doesn't. And we found that if patients have had more than one previous surgery, and you can see this factor here, there was significant difference between patients who had one previous surgery or more than one. What was quite interesting was when the subscap was torn and we did a superior capsular reconstruction, there was not much difference, whereas teres minor had a significant impact on the outcomes. So in the absence of a functioning teres minor, one has to be careful about offering this particular procedure. And here's a summary for those who are interested in taking this up as a technique. We don't have such great outcomes in patients who had multiple previous surgeries and with teres minor atrophy. So obviously we're reliant on members of team who've done procedures and followed the patients up for us. A little bit about in-space balloon. You may have heard about this degradable balloon, which can be inserted in the subacromial space in cases of irreparable tears. Again, it's one of those disruptive technologies, a bit like the electric car now, and came up with a huge amount of promise. We've had some experience with that, and we found our current experience reveals that most of the improvement we've had with our patients has been short-lived. Again, there's a big study coming out from Coventry with Steve Drew and his group, and I think that will probably give us more reliable and evidence-informed decisions on this front. Tendon transfer, I mentioned that because it's been around for many years, and lat dorsi transfer for irreparable posterior-superior cuff tears was popularized by Christian Gerber from Zurich. And I went and saw him do this operation. He does a beautiful job, a big incision in the axilla to harvest the graft and a large incision in the superior aspect of the shoulder. And this is a latissimus dorsi graft taken with whip stitches, passed through under the deltoid and reattached on the top of the humerus. It does work, and it has a place. And again, there's a lot of evidence which has been generated over the decades. The thing which has moved my practice over to superior capsular reconstruction is that with the arthroscopic techniques, we've not burnt any bridges. Even if there are patients where SCR doesn't work, we haven't violated the anatomy, and further reconstructions are easier. Whereas with the tendon transfer, it's quite a big operation with significant morbidity. And I think that big advantage of SCR has made a lot of surgeons move into the SCR territory till the evidence between the two becomes clearer. And really coming to the final option, which is perhaps the gold standard for irreparable tears, is the reverse replacement. I think it's the operation which works in a vast majority of patients who have arthritic changes, even with patients with no arthritis, so the age of 65 with lower functional demand. I think it's better to go for a reverse, because although it's extensive, the outcomes are very reliable. We have full control over the outcomes. The main issue with that is it's quite a irreversible procedure, and I think it needs to be avoided in younger people where we want to preserve the joint. So there's a lot to go through really, because the options are so many, and I thought it'll be nice to put it all together in the form of a flow chart. And this is where the current working flow chart for me is. So a patient comes in with an irreparable tear, we'll always try rehab. And if it works, happy days, no more. If rehab doesn't work and if they have arthritis on previous arthroscopy or on MR scans, then I think reverse shoulder arthroplasty is the most reliable option. If they don't have arthritis and they are not willing or unfit for reconstruction, then a suprascapular nerve ablation, perhaps a in-space balloon under local anesthetic may be an option. And for the others, where they are young, active, irreparable cuff tears, superior capsular reconstruction currently is my workhouse for treatment. When there is teres minor involvement, from our study, we have seen that SCR may not have such reliable outcomes. I'm not sure at this stage what is the correct option for them, because even tendon transfers have shown not to work so well where the teres minor is deficient. I wonder if a reverse with a tendon transfer is better. I do not know whether it's still worth pursuing SCR and dialing the graft a little bit more posteriorly would be better. That's an area which I'm not 100% sure. So I go down to a patient level decision making, and for the rest, it's reverse arthroplasty. So that's a lot of things to say about irreparable cuff tears. And I think I'll leave you guys with this chart here. Thank you.
Thank you, Puneet. Such a kind of a massive problem in terms of what we see as a shoulder surgeon, isn't it? A massive cuff tear, and you've covered all the options which we do consider when the patient comes to us. And I think your flowchart does give us and a lot of surgeons an overview of how they can base their decision making, taking into consideration the evidence available. Now, Puneet, now you touch base on the in-space balloon, and you do it under local anesthesia. How do you do that? Do you do it as an outpatient procedure, or do you do under kind of a fluoroscopy in a radiology unit?
So this is part of a little study we did, and we're hoping to publish that soon. We did it under X-ray control in our theaters. The patients brought into theater. There is a technique which the original surgeons describe. It's been published as well before, and essentially you infiltrate local anesthetic into the joint, and one can use different measuring techniques to get the size of the balloon right. And then one of your assistants will just hold the arm in the inferiorly translated position, and you can insert the balloon. So the technique is quite exacting, and unless you do that with the correct technique, it is possible that the balloon may not be sighted correctly. So it is not one for trying without appropriate instructions, is what I'd say. We've had good result with that, and again we're in the process of publishing that, so I can't go into the exact details of it. But we found that very useful technique for patients who've not got many other options. So yeah, it's interesting.
One more problem I think I do certainly face in my practice as well. A young patient coming with a massive cuff tear on a scan, and you scope them and you find that it doesn't look like you, even with extensive release and margin convergence, you can't get that to footprint without with a tension-free repair. And you've got an option of SCR. Do you kind of consent this patient for SCR when you see a massive tear on a scan?
Yeah, I have started to do that, Ravi. What I tend to say to them, because like I said, not all massive tears are irreparable, and some of the acute ones, especially, you want to get in before they become irreparable. But equally, like you said, you might go in and find that they're not. So my current scheme of decision making is I'll advise the patients that it may well not be repairable during surgery, And if it is not repairable, I would have consented them for an SCR. And I'd tell them, I go through details about what the graft material is. For me, it is acellular dermal matrix. So telling the patient what is being placed within their body, within the joint, has become very important. I think most patients want to know. So far, I've not had a single person who has not given consent. Having said that, everyone will ask some questions about that. So again, top tip is to just mention to the patient what's being put in, because people want to know. So yeah, I'd consent them for both. Absolutely.
Excellent. Thanks, Puneet. So we'll move on to our last talk by Ellie again. And we all agree that as a surgeon, we can only repair tendon, but get them back to what they want and meet the expectation. We need expertise from our shoulder-specific physiotherapy team. And so Ellie is going to talk about evidence-informed rehabilitation for cuff tears. Over to you, Ellie.
Thank you, Ravi. Oh, there's such good talks before. I feel like I'm going to have a bit of overlap with some of the other two in terms of the prognostic factors and things, but that's a good thing. And it's really nice that everybody kind of is on the same page in relation to physio at the start. I think it's really important that we kind of move away from this physio versus surgery mentality in so many orthopedic conditions, and especially this, because it is so much about teamwork. And so it's really nice to hear that's the message that everybody's been delivering. So I've called this, again, it's only 10 minutes, it's only short. So evidence-informed rehab. I've not called it evidence-based rehab because if we only did evidence-based practice, mostly we'd do nothing, because there's a huge amount of uncertainty at the moment in the literature in relation to rehabilitation following rotator cuff tears. There's a review published this month by a man called David Hyde, who did a narrative sort of expert review on that topic, so on rehabilitation following cuff tears. And it essentially showed the huge variation in protocols, the lack of understanding in terms of early versus late mobilization, the effect that can have positive and negative on tendon healing, and the fact that a lot of our protocols have existed for a very long time and are perhaps not in keeping with some more modern approaches, or even that they just need large-scale RCTs for certain things. So there is a huge amount of uncertainty, but I don't think that should be demoralizing. I think as physios, we know that what we do gets a lot of patients to where they want to be. So I think it should be an empowering thing, and if anything, show how important it is that we really understand the role and function of the cuff, and we kind of use that when things work well and when they don't, and then we use that knowledge to inform our kind of individually based rehab. So I think actually it just kind of reinforces that rote protocols are probably not the way forward, and individualized patient care is. So that's my presentation isn't going to be what you should do week on week, because it's such a varied group, and as everybody said before, it really depends on what tendons have been affected, whether it's just a simple repair, whether it's more complex, whether it's multiple tendons. So I'm going to more talk about the things that I think are important, which is, what do things look like? You know, what's the role of the cuff when things work well? What happens when they don't work well? How can we identify those patients that may or may not do well with physio? And I'll also talk about a little bit about the controversies about sort of sling management and immobilization in that immediate post-op period. So if I go immediately to, this isn't a particularly new piece of research, it's just a really nice sort of visual representation of what parts of the cuff are active during basic flexion and extension movements. And you can see here that the cuff actually has a more direction-specific joint stabilization strategy than that is observed during abduction, which is more of a global compressive role. So posterior superior cuff are more active in flexion, and subscap is more active in pulling or extension type movements. So when things work well together, you see a direction-specific nature of the cuff working well, but you will see, as I said, that even co-contraction during abduction. It is important, I think, to sort of build on, or to try and integrate some of Karen Ginn's excellent work on kind of what parts of the cuff work when, and when they work in different roles. So the cuff can work in a moving capacity and also in a stabilization capacity. So if I really oversimplify some of her excellent work, essentially, if your arm is supported and you're moving it and you're rotating it, you are more likely to be using the cuff in a mover role and deltoid and axioscapular muscles in a stability role, and the reverse is true for being unsupported. So knowing that, when we sort of hone in on our assessment, I'm sure that you've all seen big, strong, well-compensated men who have cuff tears, but because they're active and fit, they've really got good movement. And they might even have good power when you sort of externally rotate them and standing. They're really well compensated. But when you hone down and you support them and you look at certain ranges, there's certain things they can't do. So as physios, knowing how to kind of hone in our assessment, it kind of really helps with buy-in as well. And it gives us a window or an insight into what our exercise prescription might look like. So understanding the direction specific nature of the cuff, understanding the different roles in terms of mover and stabilizer, they're all really important things. There's also a really nice article, a 2017 article that looked specifically at Puneet's favorite muscle, the subscap, and how that was loaded during specific sort of functional tasks rather than just plain extension and flexion. And they looked at activities ranging from reaching to your armpit, drinking from a mug or eating with a spoon, to lifting a heavy object onto a shelf. And basically this is, it's not an actual shoulder, it's a simulation. So it's the Newcastle shoulder model, and I think about 10 newtons is about a kilogram, if I'm right there, just to give you a reference as to kind of the force going through the muscle. The same study looked at how the loading and the demands on the subscap changed or altered in the presence or absence of a supraspinatus, and I think that's really valid because obviously a lot of our patients, that's the first or the main muscle, the most common muscle you will see to be deficient or torn. And because physio obviously is the first line treatment for many of these presentations, then it's important to know how things look when that's not there. And so if you see that, you can see the huge increases in contribution required from the subscap when supraspinatus isn't there doing its normal role. And I think given that we know that patients with massive rotator cuff tears without symptoms seem to be better at activating their subscap than their asymptomatic counterparts, I think that visual representation, or certainly for me, kind of goes some way to showing us why that might be. If its demands are higher, it needs to be able to compensate for that. So I think that's really interesting. Now, obviously, in terms of if somebody with a cuff tear has surgery rather than physio as a first line treatment or as a second line treatment, and they come to you, there is a known controversy in the literature at the moment in terms of how long are people meant to be in slings for. So this title of this slide is going to look very biased. Now, in terms of putting a sling on and off, we know from not particularly new studies, the 2016 study and other EMG studies, that just taking a sling on and off, which people have to do and we recommend they do, it produces the same muscle activation levels in supraspinatus as active scaption does, and even more so in subscap. So these sorts of things are perhaps just making us question what we're actually getting out of, what really is the role of the sling. We know that slings can have a negative effect on the proprioceptive system, sensory motor system, on motor performance. There's been a pilot study by Bruno at Wright that was published not long ago, looking at the effect of early versus late mobilization in small to medium rotator cuff tears. And they basically looked at it over a year. And they looked at re-tear rates, pain, function, quality of life, quality measures. And they found at the 12-month mark no difference between the groups. So either you were told, come out of the sling when you feel able, and I think the average was about 5 days, versus 4 weeks in a sling. There was no difference in re-tear rates, no difference at the 12-month mark, ultimately in pain, function, or range. There was an improvement early on in movement, as you would expect in the early mobilization group. But I think crucially, it tells us that perhaps it's not as dangerous as we thought to allow patients to move self-guided in a safe manner. And that, combined with what you can see here, should make us maybe question our language that we use when we see our patients. Because I know that obviously if someone has a protocol, and if a surgeon's written a post-op note and it says abide by X, Y, or Z protocol, sling 4 weeks, and then a patient comes to you, they might be slightly anxious because they're doing really well, but they had their arm out of the sling at 3.5 weeks and they're worried about that, and that can negatively affect, because they have in their mind, I've done this wrong, I've ruined it, that can really affect their psychological state and therefore their sort of rehab and recovery and performance. So again, I suppose it comes around to using this to kind of inform, using the uncertainty to allow patients to guide us a little bit more. There's a larger scale study, I think, going on at Trafford at the moment, basically building on Bruno's work at Wright. So I actually think it's a good thing that there's kind of, a move away from a more timescale based approach to rehab, a more traditional orthopedic at 4 weeks, at 6 weeks, you do this, and more towards a criterion based sort of logical, approach to our rehab, which I think re-empowers physios rather than just going, I'm going to do this at 6 weeks, this at 12 weeks. It re-empowers us as autonomous practitioners to actually use our training and our knowledge and understanding of normal movement when things go well and when they don't, and how to apply that to the person, the individual in front of us. And so that's part of the reason why I've not gone, you should be doing X, Y, and Z at however many months, but I can always link to resources that are available for, like, deltoid rehab and other bits and pieces. So I think all of that, so knowing that and reflecting on our protocols and whether they fit with our understanding of the role and function of the cuff, I think that's really important. Now, because as well, we don't have it's not a long talk. I thought I would touch on something that you already asked me after the shared decision-making talk, which was the prognostic factors. Now, obviously, other than the general things like everybody else has touched on, as well as your comorbidities like diabetes and, age, socioeconomic, all that sort of stuff. In terms of the irreparable cuff tears, or maybe I should say massive cuff tears, based on what Puneet said, because obviously we will get them through with an interchangeable terminology, and maybe that's not right because they haven't necessarily tried to repair them and they failed. But anyway, people with multiple tears that surgeons have referred for physio, who does well and who doesn't. Well, you guys have already said about the tears involving 3 or more tendons and large anterior tears. So tears that involve the subscap, we know that if subscap is torn, we've got less good outcomes. And I think that for me really highlights the importance of that referral letter, depending on where you work, because obviously I'm lucky that I have the op notes for things, or I can pick up the phone and ask somebody. But I think it's really important that therapists do pick up the phone, or that surgeons make sure they're not just writing on a referral slip, rotator cuff tear, massive, rehab please, and away. They're actually telling you which muscles are intact, because I guarantee almost every patient will want to know when they see that shoulder model sat there, they'll want to know which tendons are torn. And if you can't say that, it makes us look a bit stupid, if we don't have that information to hand. So I suppose physios, it's our responsibility to pick up the phone and really know what we're dealing with, because actually it does matter. And that's where a move away from some of these post-op protocols, I think, is important to, as I said, re-empower us to actually rehab the person in front of us. So they're things that kind of a negative, associated with negative prognostic factors. But again, we can still see people out with that bell curve that do well either or, and it's important not to sort of typecast. So in terms of people who'll do well, so intact, subscap and teres minor, and interestingly, like Puneet said, that matters for both surgery and for physio. So we seem to be sitting in the patients who are going to do well seem to do well in both groups. So I think that's really interesting. And I know I mentioned before about that 12-week mark. So when a patient sat in front of us, it's a big ask to ask somebody to commit 3 months of their life to something, to then just see if they're going to be a responder. I think that's a huge ask. I mean, a lot of people wouldn't do that with a diet. You'd want to see some week by week scale improvements, if you're going to commit that lifestyle change. So I think it is important that we manage expectations, but also don't turn patients off to exercise. So if you say 12 weeks, that might be the time scale it takes you to get a really meaningful day-to-day change based on something they've said in their subjective, like putting something into a cupboard or whatever. You should notice that becoming easier by that mark if we're going to be successful with what we do, and then being clear that means you're probably going to see ongoing improvement, and that improvement might be 18 months up to 2 years if you commit. It doesn't mean that at 12 weeks what you get is where you're going to, it just means we're on the right path. So that's why it's really important along the way, as I said before, to have your measures, like to involve the patient in your assessment and to really get them to understand why you're looking at what you are and you're recording it together. So it could be range in certain positions, it could be handheld dynamometry in certain functional movements that they want to try and get back, and you can record that every maybe 4 weeks or something like that, so that you can actually keep them on the exercise wagon. Because I think otherwise, you kind of having a fingers crossed approach to something for 3 months, it's not acceptable to many people. So I think that's where building that therapeutic alliance is really important, and integrating the patient into the assessment. In terms of who's going to do well, sort of off the cuff, no pun intended. So if you if somebody comes in and they're laying on their back and they can reach up into the air actively fairly well, without having to support with the other arm. That also seems to be something that means they're going to whiz through the rehab journey a little bit quicker. But again, there's no guarantees sort of with these things. It just, these principles, I think, just highlight the importance of not just as a physio thinking there's a protocol for this, I'll just follow that, is really having that sort of in-depth understanding as to what's going on in the shoulder, that conversation with the surgeon, understanding that you need to know that to be able to genuinely adopt a position of maybe equipoise when trying to facilitate shared decision making, and all that sort of thing, that you actually do have to have that understanding. And I know that's kind of really whistle-stop tour because I only had 10 minutes, but as I said, there's other resources and things that you can find for specific rehab exercises. But yeah, hopefully it just shows the importance of looking at all those factors and working together as a team when looking towards the concept of evidence-informed rehab. In the absence of a lot of evidence, it requires quite strong teamwork and definitely keeping the patient central to that.
Thank you, Ellie. Thanks a lot for your kind of an overview and the expertise provided in how to manage these patients successfully. And I think the one take-home message definitely, from this talk is, you got to work as a team. You got to have that confidence in your surgeon, and you have to have that confidence in your physios. And I think as a team, we can make a huge difference to patient outcome, isn't it? Now, in terms of, I think I must have kind of asked this question about the prognostic factors. So when you see an op note saying that, okay, patient has a subscap repair and, SCR done at the same time, how do you change your management? Or if somebody's got just an SCR done without a subscap repair?
I think rather than changing my management, which should always be based on the person in front of me, it might change my expectations in terms of when we might get certain ranges back. So obviously, generally with a lot of cuff repairs, the things we want to avoid post-operatively is a stiff shoulder. So there is obviously quite commonly a worry about getting a post-op frozen shoulder or something like that. But if you've had a subscap repair in the mix, you can see, it might they're quite often, it'll take a while to get that 70-80% of external rotation range back. And I wouldn't worry so much about that in someone who'd had a subscap repair as well, because you might double your timescales for that in the early stages. So it wouldn't necessarily change. There are different rehab protocols for superior capsular reconstructions, which is slightly more conservative than a cuff repair. But essentially we would oh, sorry, am I still there? Yeah,
you are there.
Yeah. So essentially, I would just deal with how the person presents in front of me, and just shift my expectations based on what's actually been done. But again, the history of all of that is key.
Thanks, Ellie. And did you find a difference with the current COVID situation where you can't see a patient face to face? Did it have an impact on the outcome following cuff repairs and the rehab?
Yeah, so I think when people got lost and just sort of blanket discharged based on national advice, to clear the decks to get ready for any incoming increased demands from COVID patients. Yeah, I think those patients, and then they got picked up again. I don't want to say wasted surgery, but it certainly, there seemed like a higher proportion of patients who then didn't have anything, because a lot of hospitals weren't set up at that point for video consultation. So it was all just a quick telephone check. So there was that sort of 3-month period, I think, where there was an unlucky group of patients, and I know that everybody's talking at the moment about that increased frozen shoulder prevalence, and I think there are some people looking at that data. I've certainly seen that, but whether it's because I know frozen shoulder is multifactorial and very metabolic, that metabolic perfect storm that exists, and there's a lot we don't understand about viral load and COVID, so there could be a link, but it could equally just be that people aren't able to get the care that they would like as fast as they would like. So things are becoming more chronic and stiff, and people aren't moving as they could. So so I'm not sure about that. But yeah, initially it was a challenge. We have put together at the Alex, we've put together some online resources that we can send patients with videos and things who might have frozen shoulders and stuff like that. But it is challenging as physios, because you can do so much with video consultations, and for a lot of patients it can be really helpful But actually nothing really replaces being able to see somebody face to face, to ideally without a mask, but obviously that's not a situation we're in at the moment, because you can't, you know, ascertain somebody's sort of full response to something if you can't see them. But you know, seeing someone face to face, being able to be assessed, to sort of rule out anything else that might be going on. And a lot of us as physios, vogue or not, a lot of us do use symptom modification to guide our exercise prescription. And I think that's a good thing. I certainly do. And we can't do that over video or over the telephone. So I think it's been a challenge, but thankfully now at the Alex, we've got lots of measures in place, and we are able to, if there's a clinical need, we are able to see people face to face in our outpatient department. So we've been back to a relative normality for a number of months now.
Excellent. I think we've had a kind of a very good session here with expertise of Puneet, Andy, and Ellie, and I'm really glad that you've shared your experience with the worldwide audience. I'm sure there is lots to learn, and you know, we would get some questions. So you know, it's a kind of, you know, request to all the audiences. If you have any questions, please do forward them to nweaeducationacademy@gmail.com. And I'm sure, you know, if the COVID situation improves, then we would happy to have a clinical visitations to places like Wrightington to see what exactly is done, and the centers which are associated with us. So thank you very much to the faculty, and thank you very much to OrthoTV UK for this platform. So our next webinar is on 25th of April on a hip topic. It's on a periprosthetic fracture of femur around total hip replacement. So do join us on 25th April. Till then, bye from us. Thank you, everybody. Any questions from your side, Puneet or Andy or Ellie, to the faculty members?
If we still have time, I've got a question for Andy and Ellie each. I don't know if we have time.
Go on, fire away. Yeah.
So first one for Ellie. You know, Ellie, we see a lot of patients, a lot of them have had treatment before. And, you know, you talk to them about physio and rehabilitation, and they say, oh, I had physio already. And then they don't want to engage. And I still think it can work. How should I, as a surgeon, or people in the audience, how would they know if they've had decent physiotherapy or not? Can you give 2 or 3 top tips for surgeons to understand whether the patients engaged enough or had decent effort before or not?
As usual, Puneet, they're excellent, challenging questions. So I would say it's tough, because if someone says they've had physio before and it hasn't worked, I suppose asking them what that involved and what do they mean when they say it doesn't work, it hasn't worked. I think that would be a key thing, because then you might be able to understand they had it from this period to this period. Roughly what were they doing, and to what, you know, in what way, and what do they mean by not working? Because it could be that their expectations perhaps weren't elicited or managed or met, rather than that they were doing the wrong thing. It might have been that they were doing certain things in the wrong way. They might have had, I know we've had some issues at the moment with COVID things, you know, having to cancel lists. So it might be that they feel frustrated because they've not had the input that they've wanted to have, but what they have had has been really good. So I suppose, yeah, finding out what they mean by that, first of all, having a closer look at perhaps what they were actually doing, and if they understood what they were aiming for, that would be key, because our role as physios is to make sure that we have patients on board and we're working towards things in line with their goals, but then we're not just giving them a handout of 6 or 7 or 8 or 10, you know, exercises randomly and then just send them off for 3 weeks. That's, you know, that. And if someone's just felt bombarded with information, they've gone off with exercises, they've done them and they've just felt more sore and they've not really understood why, I suppose, then that's maybe not the interaction that they should be having. But you are right, there will be some patients that just want surgery. And given that surgery and physio offer comparable outcomes, are we wrong in trying to convince them, you know, is it wrong to try and convince them to have physio just because we think, well, it'll work and we're cheaper? It could just end up costing more overall. So I think it is, building a therapeutic alliance takes time, but that initial consultation is key. So it might, I suppose if you have a hunch after talking to a patient and asking them those sorts of questions that you think physio might still work, I suppose all you can do is refer to somebody that you think is experienced in that area, and then giving them a few sessions and then talking to the physio. I know, like we do, talking afterwards about how that's gone, because there will be times where we won't get people engaged with physio, even if we do all the right things, take into account all of their beliefs and expectations, and that's not necessarily the fault of the physio. It just could be that for that patient, surgery is the best option, and that's where they're invested, and that's okay.
That's right. That's a great answer.
And I think, Puneet, I think, we don't. I don't think many centers would have the luxury of what we have in Wrightington, where physios and surgeons do clinics side by side. And it does help a lot in coming to a kind of a consensus, or probably coming to a shared decision making, when we have both expertise trying to give their input and see what would work best, isn't it?
Yeah, no, that's true. Can I ask? Sorry, Andy. Sorry.
I was just going to say that I think you're absolutely right, Ravi, and instability is the other area where that's so key. I think joint assessment of instability patients is really fundamental, I think, to my practice, that having that physio in the same room at the same time for those especially more complex instability patients is really needed for that patient group.
I was going to ask Andy, with partial tears, I get patients who come with partial tears, the classic middle-aged 40-year-old man with a partial tear, and saying, can you do an operation to prevent it from getting worse? I don't want it to progress. And, they don't engage in physio. How do you manage them, Andy? I find them really difficult to manage.
Yeah, I suppose it comes, it's probably similar to what Ellie's just said, really. You can only, or those patients are only going to do well with rehab who have a fundamental belief in its success, and we have a role as surgeons in giving that belief or instilling that belief in patients. But there'll always be a group of patients. Clearly, it's probably a bell curve distribution. There'll always be that group of patients who, for whatever reason, are just not going to engage and or don't feel it's going to help for them. And as you say, that is a very difficult group of patients. And I suppose you just provide the relevant risks and benefits, and then treat them surgically if their pain is not going to settle. But yeah, I don't know if that answers the question you were getting at.
Yeah, no, I think sometimes we become a bit more patronizing in our thoughts about what's right for our patients, isn't it? And like you said, there are some people who just know what's right for them. So I think you're right. We need to have a decision making based on what we think, what the patients expect, what the rehab potential is. So no, I think
that's why it's really nice, some of the patient decision aid things that that I spoke about in the first presentation, because patients obviously can feel a certain way during that pressured artificial environment of a hospital during their consultation. But we know that lots of factors influence people's opinions, management options, things like their home environment, other people's experience, friends and family members who've gone through the same thing, or so giving someone that information, those decisional aids to go away with and process, I think that could be really key in that group. And then once they've gone away and done that, if they still think that's the right option for them, once they've processed it all, then who are we to, as you say, Puneet, who are we to stand in their way if it's something that we know can help?
I think, Puneet, you got to change your surname to Wright, then everything will be right, as Andrew has. So again, jokes apart, excellent session, guys. I can't thank you enough for your balanced view on such a complex problem. And I'm sure the audiences learned a lot. In fact, I've learned a lot. So thank you very much again. And I'll conclude this session. Yeah.
Thanks, Ravi.
Thanks, Ravi.
Thank you. Bye-bye.